Thank you for your patience and your forbearance. I've loved this conference today, and I'm very happy to be part of it. Thank you for the kind invitation. I think there have been a lot of good discussions today. I need more time on this timer. Right now it says 7 minutes, and the chair clearly stated I could talk as long as I wanted to. I wanted to talk about how the Phillies have completely tanked after the All-Star break. But unfortunately, back to business, our advances in energy sources, contact feedback, and other bells and whistles equal or better in terms of their outcomes at present time. So you could look at this a different way. It's kind of similar to the tack that Andre was taking. We're very insecure about AF ablation outcomes. It seems that we're exposing our patients to some degree of risk and ourselves to a whole lot of often very frustrating time in the EP laboratory to get the kind of results that we have presently. Or looking at it a different way, I remember this very clearly when I started having conversations with patients 10, 12 years ago at the outset of this, and turned a lot of patients away because I was worried about the safety of pulmonary vein isolation if they had any other choices. We're not so worried about the safety anymore. Now the conversation's really hedging on the fact that this efficacy hasn't budged as much as I would have really thought that it would in a decade of everybody in the field thinking about it more than any other single thing. This would be a very typical sort of case in the Penn lab, and we've been, to perhaps a fault, trying to hold up our end of the conversation has been completely about pulmonary vein isolation. Changes haven't come quickly at Penn. We've always done pulmonary vein isolation independent of the type of AF, come farther out from the veins. Our lines have been there have been a lot more ablations given, a lot more contiguous. And efficacy in our own hands has grown to a very small degree. How can we do better at this? We feel that pulmonary vein isolation, by the way, is really, and this is all we needed to know, all we've ever known about it, is that most episodes of atrial fibrillation at least start by triggers that come from the pulmonary veins or non-pulmonary vein sources. That physiology is very well understood. I don't think that the mechanism for pulmonary vein isolation really sums up everything that we tell it as we tell it to patients. And I make this analogy to a barricade between the triggers and the atrium. I'm sure it's much more complicated than that. And that's why it sometimes works even when we can't get durable isolation. So that devolves into a lot of arguments about how our armaments can be more extensive, how we can completely destroy the atria, especially in the setting of things that we do even worse, like persistent or long-standing persistent atrial fibrillation. I like this review. You get kind of a sense that the more we ablate, the better we do, at least as reported in our literature, which is a little sketchy at times. I'm very depressed to have to admit. But the overall conclusion to this and all determinations of this is it looks like we don't really know. None of the things we've chosen to do, none of the armaments have been successful enough to really say that we're where we want to be for taking care of our patients. So how can we make this better? I think that there are some very exciting emergent techniques, some of which I'll talk about today. I'd like to say that this is true. It's certainly true in my own mind. I'm not sure it's true in the field, that we're not really so interested in arguing about whose lesion set is superior to whose anymore. It's close to true, not exactly true. It seems like that is missing the biological point that we really have to address. I think that methods to improve durability of ablation lesions, to enhance the response to ablation, or to improve understanding of atrial fibrillation, not just as a single disease process, but kind of a spectrum of maybe 100 different disease processes depending on the individual patient characteristics that we're talking about. So another way of saying that is our technology could get better or our understanding could get better. I've always hoped it would be our understanding, but I think technology probably has a good head start on this one. So this is the entire universe of things that I could think of, and I will concentrate on these four, kind of in turn with short descriptions of where these fields might be going. So this is a topic that would have went very well in Andre's talk too, kind of is building on that pretty clearly. If we really could do durable, reproducible pulmonary vein isolation, how would that do for us? This is an oft-quoted slide looking in a way at accidental surgical pulmonary vein isolation in the setting of double lung transplant. So atrial fibrillation is very common in patients who need thoracic surgery. In patients who have thoracic surgery of different sources or different indications or single lung transplant, atrial fibrillation is very common in follow-up. In double lung transplant, after a blanking period, it's essentially absent. So I think this is the promise. Can we deliver it? So one way of looking at this is, can we do something different than radiofrequency energy? Cryoablation might be an indication for this. In our lab, cryoablation is very much about ice imaging. And I don't think I'm going to belabor this point right now. These movies show a leak when we're trying to cryoablate in the left inferior pulmonary vein, shown with contrast phonography. To my eye, ice is a better way of viewing that. Maybe if we could just play that, that movie. The second one, yes. This leak is exactly the same sort of visual stimulation that you would have with contrast phonography, but the beauty of ice is that you can move the balloon in real time and fix it. So if you could play the bottom right AVI. So this is after we've made that manipulation, that leak is gone. This is the color coming from the adjacent left superior pulmonary vein. The concept of cryoballoon, or the concept of any balloon delivery, is really very sound. Andre was showing that pulmonary vein isolation, when you're trying to make a big circle of individual RF point lesions, the circle fails if one spot is bad. So it seems like a balloon that would have uniform application of whatever power system would do a better job. We're not independently having to verify each individual lesion. The problem is it doesn't work out observationally so terribly much better. This is Doug Packer's work in the STOP AF IDA trial for the cryoballoon. It was the prior technology of the balloon. The newer technology, which has more uniform coldness delivery across the surface of the balloon, might in fact be different. But these are sorts of results that would be very familiar to what we were used to seeing from radiofrequency energy. So there's a little bit of a disconnect here. Now people are talking about the idea, and I hope that it's true, that with the new balloon with more uniform and more powerful cooling, there might be better results. But there's a dynamic there too. With better results, more power, we're also talking about side effects and complications that we hadn't seen previously with cryoablation. And how I look at that dynamic was kind of played out by this experience. This is with high-intensity focused ultrasound, the HIFU balloon. This is just a case report of what this more intense power looked like. The balloon looks as though it would fire all around the vein at exactly the same intensity, but there are hot spots and not so hot spots. The result of that in this particular operation was a very much increased incidence of atrial esophageal fistula. Just to make the point, not to rag on HIFU, but to make the point that we're always wishing for more power, and then sometimes we're kind of sad, and our patients are more sad still when we in fact get it. This is the way we handle this in the lab at Penn. We're really excited about this right now. If you could play that video. So this is just, we have an ablation catheter and a lasso in the heart in a spontaneously breathing patient. Look at what happens to the ablation catheter when the patient is so rude to take an inspiration. So we kind of get, or at least we believe in our hearts, that we're pretty good at manipulating the heart, manipulating the catheter around the heart. As the heart's beating, when the lungs breathe, when the diaphragm moves, the heart hurtles through space, and the catheter does the same. We use jet ventilation, which is very high frequency, low tidal volume respiration. If you could play the movie on the left. So we have the same sort of setup. The diaphragm doesn't move at all. The catheter is moving with the heart, but there's no hurtling through space. This kind of gives us a fighting chance to be able to balance the tip of the catheter at the end of the heart when we're standing 110 centimeters away. This was an observational study that it would have been better done randomized, and it's one of those things that we got so enthusiastic about the technology, we wouldn't go backwards and do the proper scientific study. So Matt Hutchinson, one of my colleagues, did this instead. We looked at 3 sequential groups of 300 patients who got sicker over time. The percentage of non-paroxysmal atrial fibrillation went up from groups 1, 2, 3. The left atrial size went up, and particularly in the setting of Philadelphia, the body mass index went up, groups 1, 2, 3. Despite that, the groups intensively incorporated more technology as we went. So the first group was just basic stuff. The second group was image integration in a steerable sheath. The third group integrated jet ventilation. And we see real increases in success rates. I think important, significant improvements in success rates despite the patients getting sicker. We think this is a good indication, not as strong as it would have been if it were randomized data. We're still pretty excited about it. Andre is starting to talk about force-sensing catheters. I'm going to skip this slide. The idea behind that is borne out, at least in concept, in this picture. You can imagine that there is an intersection between the power delivery and the force delivered at the catheter or tissue interface. And there would be a sweet spot for this. Now, the sweet spot hasn't really been successfully defined in my level of confidence. But you could also imagine too little contact to really do anything. And also, I think very importantly, too much contact or too much contact times power that would lead to a real risk of perforation. I would have said before handling these catheters that I am an expert in moving catheters around the heart, and I can feel what the catheter is doing at the tip of the tissue, and I was entirely wrong. We have no sense of this, no tactile sense of this at all. Have no ability to be able to understand this by looking at the catheter under fluoroscopy. We have some indication from intracardiac echo, but this is really going to change, I think, everything. This is one of the company's feedback loop for this. You can see that the catheter is 2 things. It's touching the heart at a very high force that increases with each movement of the catheter or movement of the heart in systole, but that this stays constant over long periods of time, meaning that the catheter is really still and not moving around, bouncing to different things. The force is within this anticipated sweet spot, not too small and not too big. Providing this real time allows us to adjust things if they're not right. Does it have any impact? This is one way of looking at it. This was Takata with blinded collection of this data, and it just showed that even though the investigators were blinded, if you look at groups that had good contact force as opposed to poor contact force, patients did better in terms of avoiding recurrent atrial fibrillation. If you look at the EFICAS studies, which were in Europe, EFICAS 1 blinded to operator blinded to contact force. EFICAS 2, that contact force information was available real time to the operator. There was an important increase in the number of veins that were isolated upon recheck. And more of the ablations were performed within that sweet spot we were talking about. Taking this another different way, this is another technology that we're starting to investigate at Penn and obviously at very, very many other places. Are there better ways to develop lesions? Some other ways that kind of disturb the apparent dynamic between power and risk. So this hybrid surgical catheter ablation, I think, takes advantage of some of these possibilities. With this new catheter that's used for the surgical part of the hybrid ablation, that is a helical RF coil, enhanced by it being large, 3 centimeters by 1 centimeter, hydro-cooled just like ablation catheters are, and with suction incorporated into it so the heart cannot escape. Contact is nearly perfect. And finally, although delivered from the epicardium, safe because it's unidirectional. So you can deliver only at the heart, rather than at the heart and the surrounding tissues like the lungs and the esophagus. So this is in vitro, so it's not exactly fair, but a comparison between the lesions that are developed in vitro with the nContact catheter delivered from the epicardium at nominal settings versus a thermal catheter at reasonable settings, maybe a little underpowered because of the in vitro margin from the endocardium. So if we could deliver more consistent lesions, would this help us? Perhaps. The problem with this and the need for hybrid ablation then is that this catheter is delivered through a small incision below the xiphoid process, and endoscopic surgery techniques are used to make a small incision in the pericardium. The ablation catheter is introduced then into the pericardial space and then inherently limited in terms of its scope. It can go a lot of places around the heart, particularly in the posterior left atrium, but is not capable of crossing the pericardial reflections by the superior portions of the veins. There's no capacity for doing dissection during this procedure. There's not enough exposure. So the surgeons do what they can do, and then the ablation has to be completed in the EP lab. What that can look like, in the absence of a lot of adhesions of pericardial fat, is that these big blue lesions correspond to the surgical applications of lesions. I think some of the more important parts of this you can't quite see. There is a lesion on the ridge that we have so much trouble with the catheter ablation. And then the red dots are completion lesions that performed in the EP lab. This has not been exposed to a great deal of intellectual rigor. There's one paper in Heart Rhythm in terms of the American literature, but is beginning to look like in scattered reports, many less than completely vetted experiences, that in a mostly persistent, sometimes a long-lasting persistent group of patients with atrial fibrillation with more comorbidities than are general for a catheter ablation sort of experience, the results are better than we would expect. So more to follow. I want to summarize this way, and I talked about this a little bit before. So when we look for progress in our field in terms of catheter ablation, progress in general can be made by better technologies or improved understanding of the pathophysiology of the disease process. I would like to bet on the second. I think that the final eureka moment is going to come and we can understand atrial fibrillation a lot better and apply reasonable strategies to treat it better. But like I said before, I think technologies have a big head start on us. And I think that there are technologies that will be helpful in making those intermediate incremental steps. I think that of all the technologies that improve lesion performance, and particularly important without reducing safety, appear to be the relatively low-lying fruit in our next stage of improving catheter ablation for atrial fibrillation. Thank you for your attention.